Okay. Hello, everyone. Welcome to the presentation. Thank you for finding the time to join us. My name is Jesse Lehman, and I'm the founder of Kerrier, and we make the Kerrier Absorbable Bead Kit for local drug delivery. Since launching 8 years ago, Kerrier beads have been used successfully as an infection management tool in a wide variety of cases all over the world. Veterinary surgeons are using the beads to deliver high concentrations of antibiotic locally to sites where infection is present or anticipated. Calcium sulfate in the kit is surgical grade and fully absorbable, and the sterile kit is easy to use and affordable. We are excited because today Dr. Jessica Kinsey will be sharing some of her experience with calcium sulfate beads. At the end of Dr. Kinsey's presentation, we will answer questions, so please use the Q&A box to send them in. This webinar will also be recorded and made available at kerrier.com. So let's get started. I'll pass it over to Dr. Kinsey.
Thanks so much for coming. My talk is entitled Surgical Site Infections in Total Ear Canal Ablation and Lateral Bulla Osteotomy Procedures. Our clinical experience with calcium sulfate beads. Total ear canal ablation and lateral bulla osteotomy is a commonly performed procedure in veterinary surgery. The total ear canal ablation is considered a salvage procedure. It's typically recommended after family practice veterinarians and dermatologists determine that medical management is no longer likely to be successful in treating infections or eliminating the discomfort in patients with end-stage oral canal disease. Prior to surgery consultation, many of these cases have been treated with multiple topical and systemic preparations of antibiotics, antifungals, and immunosuppressants. As a result, multi-drug resistant infections are common. As surgeons, we're often tasked with performing a surgery involving a very abnormal anatomic structures laden with multi-drug resistant bacteria. We face a significant challenge in treating these cases in a way that optimizes outcome, minimizes risk for complications, limits associated cost, and prevents the progression of antibiotic resistance. I wanted to share my experience with Kerrier's antibiotic impregnated calcium sulfate beads because I feel that the use of these beads has helped me to more successfully treat these often challenging TECA-LBO cases. With the total ear canal ablation procedure, surgeons carefully dissect out and remove the horizontal and vertical canals in their entirety. The main indications are severe otitis externa, oral canal neoplasia or hyperplasia, para-oral abscessation, or trauma. Because concurrent otitis media is present in up to 89% of cases, and because the auditoid tube provides insufficient drainage for the post-TECA bulla, a lateral bulla osteotomy with scrupulous removal of the bulla epithelium is now performed in association with the TECA procedure as the standard of care. The TECA-LBO has a 93 to 95% success rate. However, it can be a challenging procedure. Common complications include hemorrhage, facial swelling, neurologic damage, ocular issues, and surgical site infections. Hemorrhage is the most common intraoperative complication. We see it at about 3 to 14% of cases. It's usually attributed to damage to the retroglenoid vein at the level of the retroglenoid foramen, which you can see in blue here, but damage to the carotid artery or smaller vessels is also possible. Hemorrhage is most commonly regarded as an inconvenient complication that inhibits visibility and progress. However, in one study, 5% of cases required transfusion. Neurologic complications and infection are the most common postoperative complications. The most common neurologic complication is facial nerve paralysis or pheresis. This is reported in about 13 to 50% of cases in the early postoperative period, and permanent paralysis can be seen in up to 15% of cases. The significance of permanent paralysis appears debatable. In some reports, patients have a pretty severely compromised quality of life due to their inability to blink, while in other sources, dogs adjust to blink using ocular retropulsion. Since tear production is typically uninterrupted, long-term lubrication may not be required, and the quality of life can be pretty reasonable. Damage to the vestibular apparatus can occur. This typically occurs in about 2 to 30% of cases and typically presents as nystagmus, head tilt, and vestibular ataxia. It's typically considered that vestibular deficits are rarely permanent in dogs if they were not present preoperatively. In one study that looked at complications in TECA-LBO surgery in 121 ears, about 11% had a head tilt postoperatively and 5% had nystagmus. The head tilt was permanent in about 5% of cases, whereas the nystagmus resolved in all the cases. In another study looking at long-term outcomes in 107 dogs, vestibular adverse events were noted in about 17% of cases, but they weren't permanent in any dog. Damage to the oculosympathetic pathway and resulting Horner syndrome can be seen. This occurs in about 3 to 8% of cases and is rarely permanent. Hearing loss is a commonly considered adverse effect. Studies show that dogs with chronic otitis media have significantly decreased hearing preoperatively. In a study looking at 82 dogs who underwent TECA-LBO, owners perceived that about 52% of these dogs had decreased hearing postoperatively but maintained some ability to hear. Similarly, in a smaller study that looked at brainstem auditory evoked response in 7 dogs who underwent bilateral TECA-LBO, most of the dogs had recordable bare response to air and bone stimuli before and after surgery, but at all time points, all of the responses were abnormal. Surgery site infection is a somewhat common postoperative complication and is reported in 5 to 82% of cases. The range likely exists because postoperative signs of infection associated with previously infected tissue can be kind of hard to categorize. From a practical perspective, clinically significant surgery site infections can be categorized into 1 or 2 forms: incisional dehiscence and infection, and abscessation and recurrent otitis media. Incisional dehiscence and infection tends to be an early and superficial post-surgery site infection. Some sources say this occurs in less than 30 days after surgery, but it's usually within the first 1 to 2 weeks. Abscessation and recurrent otitis media tends to affect deeper tissues and can take longer to be identified. Kind of 90 days is like the cutoff, but many of these infections occur 5 to 6 months postoperatively. Most studies have a really short follow-up period, so most surgery site infections reported are incisional dehiscences and infections. In a study of 79 canine ears treated with unilateral and bilateral TECA-LBOs, wound complications were seen in about 28% of ears. These wound complications were further characterized as incisional infection, incisional drainage or dehiscence, suture reaction, and seromas. No wound complication required surgical revision. In a study looking at short and long-term complications in 120 patients who underwent TECA-LBO, about 13% of cases had incisional dehiscence or infection diagnosed within the first 30 days postoperatively. About 8% had abscessation diagnosed at least 6 months postoperatively. In another study looking at 142 ears that underwent TECA-LBO for the treatment of otitis externa, 6% of cases had developed recurrent otitis media, a mean of 5.5 months after surgery. Regardless of exactly how it's described, surgery site infection is a significant concern for the post-TECA ear. The results of risk of surgery site infections are greater with the TECA-LBO procedure than most other soft tissue procedures. Possible risk factors include the presence of resistant bacteria preoperatively, the potential for spread of infection from within the canal to the bulla epithelium and the bony structures, the potential for tissue trauma or inadequate debridement, and longer surgical and anesthetic times necessary to facilitate some of these TECA-LBO procedures. Many TECA-LBO patients are suffering from polymicrobial multi-drug resistant infections. In multiple studies, cultures taken at the time of surgery isolate more than one bacteria in 40 to 60% of cases. Staphylococcal infection is the most common. We see this in about 50% of cases. Up to 40% of the isolated staphylococcal bacteria are methicillin resistant. Staph pseudointermedius is pretty consistently the most commonly isolated organism. Streptococcus and Enterococcus are also frequently isolated. We also see Peptostreptococcus, Pseudomonas, Prevotella, E. coli fairly often. Other isolates are less common. In a recent study describing 12 dogs from multiple institutions that experienced incisional dehiscence post-TECA-LBO, authors compared cultures taken preoperatively, at the time of surgery, and at the time of incisional dehiscence. Only 4 of the 12 dogs were cultured preoperatively, but 100% of these dogs cultured positive for methicillin-resistant staph. The infections were often polymicrobial, Streptococcus and Corynebacterium were also pretty commonly isolated. While specifics were not discussed, it's likely that these cultures were not obtained from the bulla. It is really important to remember that cultures taken from the bulla post-lavage do decrease the number of isolates by about 33%. All of the dogs had intraoperative cultures. 75% of these were obtained from the middle ear, 25% from the canal. As in the aforementioned studies, staph was the most common in many of these cultured monopool bacteria. When these cases experienced dehiscence, the median time to dehiscence was 11.5 days post-op. Staph was isolated in 83% of the post-dehiscence cultures, and 80% of these were methicillin resistant. E. coli was the second most common isolate. Most of these were fairly sensitive. Pseudomonas was seen in about 17% of cases, and other organisms were less frequently isolated. Of the dogs that dehisced, only one dog had the same bacteria isolated from the TECA-LBO culture and the dehiscence culture. Antibiotic selection for TECA-LBO cases is often a challenge. While patients are awaiting surgery, general practitioners, dermatologists, and surgeons are often fighting to minimize preoperative infection with antibiotic choices that are aggressive enough that our infections are controlled and patients are comfortable, but not so aggressive that bacterial resistance progresses. When surgeons choose perioperative antibiotics, they must consider the ear canals and bulla are often infected. Infections are usually polymicrobial and sometimes resistant. And often recurrent surgical infection with different microbes is a postoperative complication. Empirically chosen antibiotics are typically broad spectrum, but they're not always efficacious against the resistant flora. In a study that assessed long-term outcome in 120 cases that underwent TECA-LBO, cefazolin and unicin were the most commonly used perioperative antibiotics, and clavamox and sulflexin were the most commonly used postoperative antibiotics. About 30% of dogs had cultures that isolated bacteria resistant to the empirically prescribed postoperative antibiotics. In the study, which investigated 12 dogs that had a surgery site infection post-TECA, cefazolin and unicin were also the most commonly prescribed perioperative antibiotics. 70% of dogs had cultures that isolated bacteria resistant to these antibiotics. Surgeons combat suspected multi-drug resistant infections in varying ways. Realistically, the options are to treat empirically with varying levels of aggression and then adjust the treatment based on sensitivities, or to forego antibiotics until the culture results return and then treat based on sensitivities. Cultures can take 3 to 7 days to return, with extended sensitivities adding additional time. When antibiotic administration is delayed or not aggressive enough, there's concern that complications may occur. In a study looking at 120 dogs treated with TECA-LBO, empirical antibiotics were not administered in about 23% of cases. These patients were 2.8 times as likely to have neurologic issues in the early postoperative period. If a positive culture returned and antibiotics were not administered within about 30 days of surgery, these patients were 10 times as likely to require a surgical revision. Antimicrobial impregnated materials, specifically antibiotic impregnated calcium sulfate beads, like those commercially available through the Kerrier company, may be quite valuable in that they provide a way for surgeons to treat infections aggressively, without delay, and with minimal risk for adverse effects. Medical grade calcium sulfate hemihydrate powder became commercially available through the Kerrier company in 2018. The powder can be mixed with saline and several antibiotics to create antibiotic impregnated calcium sulfate dihydrate beads. This product is similar to plaster of Paris, which is available as calcium sulfate dihydrate, but the plaster of Paris is not typically medical grade, and the impurities can disrupt resorption to some degree. Calcium sulfate dihydrate is a rapidly absorbable biomaterial. It takes the beads approximately 30 to 60 days to dissolve in aqueous media or tissue. During dissolution, the beads slowly release antibiotic, calcium, and sulfate. Because the beads are radiopaque, their dissolution can be monitored radiographically. Calcium sulfate beads have been utilized clinically and experimentally for both osteoconduction and local antibiotic delivery. The clinical use of antibiotic impregnated beads was first reported as a treatment for dogs with osteomyelitis in about 2008. The original report basically concluded that the 6 dogs that were treated had no complications and the osteomyelitis resolved in all the dogs with follow-up. Since this time, reports detailing the use of calcium sulfate beads in the treatment of additional osteomyelitis cases, bony sequestrum, implant infection, and as a preventative for high-risk cases have been published. In addition, multiple studies looking at elution profiles and storage and stability have been published. When antibiotic impregnated calcium sulfate beads are placed in a surgical wound, they can achieve sustained elution of the antibiotic at higher concentrations than could be achieved through systemic administration, while concurrent systemic concentrations remain low. While there's no published data specifically investigating antibiotic elution in dog tissue, in a study assessing the treatment of experimental osteomyelitis in rabbits treated with tobramycin impregnated calcium sulfate pellets showed significantly improved eradication of infection when compared to those treated with IM tobramycin and calcium sulfate placebo pellets. Tobramycin concentrations between 2 and 6 mics per mil are considered therapeutic. Systemic concentrations above 12 mics per mil should be avoided. When tobramycin was administered via IM injection, serum concentrations quickly peaked around 8 mics per mil and then fell to about 4 mics per mil until the subsequent dose. When tobramycin beads were placed, systemic concentrations peaked at 6 mics per mil and then were below detectable levels after 3 hours. The local concentration for these tobramycin pellets was 12 mg per mil on day 1. It slowly decreased to 2 mics per mil over 7 days. Elution studies using antibiotic-impregnated calcium sulfate beads are readily available for amikacin, gentamicin, penicillin, cefazolin, ampicillin, unicin, vancomycin, meropenem, and a bunch of drugs we don't use quite as much in veterinary medicine. The aminoglycosides, specifically amikacin, are attractive antibiotics to using calcium sulfate antibiotic-impregnated beads because they have a small chemical structure and are polar, water-soluble weak bases. These properties allow fast and complete diffusion into the surrounding environment. Amikacin is quite broad spectrum, it's concentration dependent, and the resistance is uncommon. This is likely because it's not heavily utilized empirically, and because inducible resistance is a challenge as its conformation limits enzymatic binding and destruction. In addition, amikacin has a known post-peak effect, meaning that it continues to kill bacteria for about 8 hours after the levels drop below the MIC. While there are many advantages to amikacin use, we do have to be a little cautious that fast elution can shorten duration. In general, we consider the amikacin breakpoint in tissue to be 2 to 4 mics per mg. When we administer aminoglycosides, we attempt to reach tissue concentrations that maximize at about 8 to 10 times the breakpoint, so about 20 to 40 mics per ml. And we want to keep the systemic concentrations below 2 mics per ml to minimize toxicity. Typically, a parental dose of 15 mg per kg sub-Q or IV once daily can accomplish this, but risks are high enough that there's hesitancy to use this for very long, and careful monitoring for signs of renal tubular necrosis is required. The optimal dose for amikacin and amikacin impregnated calcium sulfate beads is not known, but we do have information to guide us. So there was a study by Olson that looked at elution profiles for amikacin beads of various concentrations and sizes. In this study, regardless of the concentration and size, 150 mg of amikacin was placed in 6 mils of buffered saline. Peak concentrations achieved ranged from 7 to 27 mg per mil. So this is roughly like 1,700 times to 6,700 times the MIC. The therapeutic duration was from about 6 to 9 days. Protocol for mixing the beads with amikacin is available from the manufacturer. A recent publication by Hartman investigated the effects of dark temperature controlled storage on calcium sulfate beads impregnated with amikacin and vancomycin, and also provides some helpful information with regard to bead function. This study assessed function of the beads after 0, 3, 6, 9, and 12 months of storage. When a 3 millimeter bead was placed in cultures of MRSA, MRSP, and Pseudomonas, the zone of inhibition was effective or greater than 20 millimeters for about 4 to 7 days, regardless of how long the beads are stored. So in terms of our experience, I've been using amikacin impregnated calcium sulfate beads by Kerrier since 2019. I initially utilized them in orthopedic explant cases. In August of 2020, I used amikacin impregnated calcium sulfate beads in a case that had dehisced after a TECA-LBO procedure. The clinical dehiscence was pretty severe, and the TECA-LBO culture had isolated an MDR, E. coli, and Proteus. Both were sensitive to amikacin and not much else. I was a little concerned about the ototoxicity risk, of this location, but I placed the beads kind of anyway, and the case healed really nicely with no complications. So I started using amikacin impregnated beads in TECA-LBO cases that I thought were high risk. And I pretty quickly felt like I was seeing less incisional issues in these cases, so I transitioned to using the beads with every case. Around this time, I also started using Nocida in every TECA-LBO case. Early on, there were some concerns about using Nocida in contaminated procedures, but after having almost no complications, I felt pretty comfortable doing this, and this did help to shorten hospitalizations and minimize TECA-LBO costs. Because I've now been using amikacin impregnated calcium sulfate beads for about 6 years, and I've seen minimal adverse effects and very good clinical results, I was compelled to report on my experience. I'm in the process of creating a very small retrospective study looking at the use of amikacin impregnated calcium sulfate beads in TECA-LBO procedures in dogs. The project is still very much in preliminary phases, but essentially we searched the records for all of the TECA-LBO procedures performed by a single surgeon at 2 institutions from 2018 to 2026. Cases were included in the study if the patient underwent unilateral or bilateral TECA-LBO and had disease confined to the ear canal, and a complete medical record. The data that were included was a pretty standard data, pretty well everything I was able to look at, including signalment comorbidities, history, PE findings, diagnostics, surgical findings, long and short-term complications, and survival data. In addition, some owners voluntarily answered a questionnaire. Prior to surgery, the beads were created using the sterile technique and following Kerrier's mixing instructions for 500 mg amikacin, so the non-standard mixing instructions. This involved combining Kerrier calcium sulfate hemihydrate powder and saline and mixing, and then adding the amikacin and mixing, and then placing the mixture in the provided silicone bead mat and waiting at least an hour to allow the beads to solidify. An approximate 50-50 mixture of the 3mm and 5mm beads was created. Once set, the beads were placed in no additive tubes and stored in dark, temperature-controlled OR storage for up to 6 months. Certainly don't think any of them lasted longer than that prior to use. Our preparation protocols for better or worse sort of evolved over time. Currently, we use ethylene oxide to sterilize the no additive tubes, tiny funnels, and a drape. We utilize this kit with the commercial Kerrier kit and mix and divide the amikacin into 5 tubes. Each tube contains about 4 grams of beads and 100 mg of amikacin. In preparation for the TECA-LBO, all the patients were anesthetized. They all had analgesia, usually some form of a mu agonist, a lot of dexmedetomidine or midazolam, sometimes ketamine. For most of the patients, we did great auricular and auricular temporal nerve blocks. All the total ear canal ablations, I think, were done with pretty standard techniques. We did a generous lateral bulla osteotomy, and I certainly made every attempt to remove the bulla epithelium. The majority of the canal and the bulla epithelium were submitted for histopath. A sample of bulla epithelium and canal adjacent to the bulla were submitted for culture. In cases of bilateral surgery, both canals were submitted individually for histopath, but the culture was a combination of the bulla and canals. For cases treated without antibiotic impregnated beads, the site was copiously lavaged. A purse string was carefully placed to close the deeper subcutaneous tissue and minimize dead space, and then the superficial subcutis and skin were closed routinely. For cases treated with the beads, lavage and closure was similar. However, the beads were placed between the purse string and the superficial subcutaneous closure. Nocida was also placed in the subcutis and the skin. Thus far, the study includes 30 cases, 39 ears. There are 14 cases or 18 ears in which no local antibiotic treatments or beads were utilized, and 16 cases or 21 ears in which amikacin impregnated calcium sulfate beads were placed. All of the dogs had typical signs and history consistent with chronic end-stage otitis externa. There was concern for a mass in about 5% of the ears without beads, 19% of the ears with beads. When histopathology was assessed, 1 of 21 dogs, a dog in the bead group, had ceruminous gland adenocarcinoma. All the other dogs had benign disease. Of the 30 cases, 24 80%, had positive cultures. Cultures isolated 36 bacteria from 24 dogs. 46% of the infections were polymicrobial. For those of you math wizards, one of the dogs had 3 isolates. Approximately 59% of the cases grew a staph of some form. About 43% of these staphylococcal organisms were methicillin resistant. About 30% grew in Enterococcus, 25% grew in E. coli, but not all of them were minimally resistant. 17% grew Pseudomonas. About 75% of the Pseudomonas were multi-drug resistant. Other isolates were less common. Of the 36 strains of bacteria that were isolated, 61% of the strains had samples that were tested for amikacin sensitivity, and 95% of these were susceptible. The resistant bacteria was a beta hemolytic strep. All of the Enterococcuses and some of the staphylococcal cases were not tested due to the likelihood of resistance in these strains. Intravenous, perioperative, and oral postoperative antibiotics were used in all cases. Unicin and cefazolin were the most commonly used perioperative antibiotics, just like everyone else. Clavamux, clindamycin, and marbofoxacin were the most commonly used postoperative antibiotics. When we looked at the cases treated without beads, 71% of the dogs cultured at least one organism that was resistant to the empirically prescribed antibiotics. When I looked at the cases treated with the amikacin impregnated beads, in addition to the empirical oral antibiotics, only 19% cultured an organism resistant to the empirical antibiotics. The most common intraoperative complication was hemorrhage. This occurred in 19% of the cases with beads and 16% of the years without beads. All hemorrhage was stopped with either saline and thyme or gel foam, and no case was transfusion required. The most common postoperative complication was facial nerve paralysis in early recovery. In both groups, this was seen in 67% of cases. The majority of the cases normalized before the 2-week check. The way that we kind of categorize this, if the blink was not reassessed as normal by the surgeon, the paresis or paralysis was determined to be permanent. Permanent facial nerve paralysis was seen in 6% of cases in which beads were not used, 14% of cases in which beads were used. One case in the no beads group had bilateral vestibular signs. These resolved by the 2-week check. No cases in either group had Horner's syndrome. In the 14 cases or 18 years in which no local antibiotic treatments were utilized, 5 cases, 6 ears or 33% of the ears, had incisional infection with dehiscence that prevented them from being fully healed by the 2-week postoperative check. 2 of these cases, or 11% of the ears, required a revision procedure. In the 18 cases, 21 years in which amikacin beads were placed, 1 case underwent incisional revision and was not healed by 2 weeks postoperatively. Thus far, no cases in either group have suffered abscessation or recurrent otitis media. I did want to talk a little bit about the incisional complications in the group treated with the calcium sulfate beads. We did see a couple cases that had a little discharge that looked like serum and dissolved calcium sulfate seeping through the incision. The first case was seen very early on. We didn't really know how to interpret this, so I did a culture. The culture was negative, and the dog was nicely healed by the 2-week check. With the second case, the dog was traumatized. It had traumatized its own pinna, and so she was sedated to address the pineal laceration. At this time, the surgical incision really looked primarily intact, but I could squeeze that white cloudy material from the incision. And so the incision was open. The material was assessed grossly and microscopically and determined to be inconsistent with infection, and the incision was reclosed. This incision was healed at 3 weeks post-op. The median follow-up in terms of physical exam was performed by the surgeon was 23 days. The average was 185 days. About 60% of owners filled out our questionnaire this far. About 50% of the dogs who underwent TECA-LBO are still alive. For the deceased dogs, the median survival time was about 1,100 days. No dogs were documented to have died of their disease. According to owners, 1 dog in the dogs treated without beads group had permanent facial nerve paralysis. No dogs in the dogs treated with Beads group had any long-term complications. When asked to grade their pet's quality of life on a scale of 1 to 5, correlating from poor to excellent before and after the TECA-LBO, regardless of bead use, the average before score was 4, the average post score was 2, which is fair. The average grade after surgery was 4, which is very good. When asked to rate their overall success with the procedure on a scale of 1 to 5, from regretful to very satisfied, both sets of owners chose very satisfied. Even in its preliminary form, I suspect that our study has all the limitations of a retrospective study and may lack the power for strong conclusions, but it's been my experience that amikacin impregnated calcium sulfate beads have decreased my incisional infection and dehiscence rates and increased the percentage of my cases that are fully healed by the 2-week check. I've seen no significant complications with the beads, and I really think we may be able to help dogs with this product. There's still a lot of work to be done. We don't know the optimal dose for amikacin impregnated calcium sulfate beads. We chose our dose of 100 mg of amikacin and 4 grams of calcium sulfate per ear because this is the volume of beads that seems to nicely fit in the canine ear and because it was well tolerated in early cases. Why I suspect that our in vivo tissue concentrations were similar to the in vitro concentrations reported in the Olson study, where 150 mg of amikacin was placed in 6 mils of saline. We don't really know exactly what concentrations we're reaching in the tissue. Similarly, we don't know how long we're maintaining concentrations above the MIC. I do think it's important to note that while the Olson study reports concentrations above the therapeutic concentration for 6 days, for the low concentration 3 millimeter and 5 millimeter beads, which is what we used, the concentrations maintain above the MIC for significantly longer periods. In this graphic, it looks like the entire 28-day study period. In addition, the amikacin beads, when they drop below that MIC, amikacin does continue to kill bacteria because it's post-peak effect. So we probably get longer in vivo duration than kind of what we realize. That being said, from a practical perspective, if the amikacin impregnated beads can generate effective concentrations of amikacin to kill the bacteria until the culture results allow targeted systemic treatment, the beads have still helped our patients significantly. One of my concerns in using the amikacin impregnated beads was odor toxicity. Aminoglycosides cause both vestibular and auditory odor toxicity, and they do this through active uptake by binding to the hair cells of the cochlea. While it's hard to say that I haven't caused auditory odor toxicity with this drug, no cases in which I utilized the amikacin impregnated beads had significant vestibular odor toxicity. It has been shown that divalent cations like ionized calcium can competitively bind to the hair cell amikacin uptake sites and decrease uptake, which decreases toxicity. I think it's possible that as the calcium sulfate dehydrate dissolves, the production of ionized calcium prevents amikacin toxicity via this mechanism. Thank you for attending. There's some references, and I'll take any questions.
Well, thank you, Dr. Kinsey. That was fantastic. Excellent presentation. We really appreciate it. Are there any questions out there? I'm looking here in the chat box. There is a Q&A box where questions can be sent. Please do so. Any questions out there? I guess you must have covered everything.
It looks like there is a question. Well, there's a
Yeah.
hand. Let me see if I can figure out sorry, what the question is here. Are you able to see the actual question?
Yeah, I'm looking here in the chat box and I'm not seeing it. Let's see. Hmm. Oh, here it is. Maybe not.
I think it's basically a question about what to do before we refer these cases for surgery. Um, so I think resistance is a really big problem that we're seeing with TECA-LBO cases, and so as we're getting these cases ready from kind of the get-go to get to the hands of the surgeon, or even as we're managing them and hoping that they never have to see a surgeon. I think it's really important to depend on the cytology. That when we're assessing to see if there's yeast or bacteria, or any of these underlying microbes in these cases, that we're assessing everything with cytology, that we're treating only, the organism that we're really seeing on the cytology, and that we're not using really aggressive antibiotics very early on in the cases. I think in general, there's certain antibiotics that we probably should be preserving for surgical cases. And so if we're getting to the point where a case that is just an ear infection requires amikacin, it probably needs a dermatologist and a surgeon. I don't think it's something that we should be treating, with antibiotics before we're going to surgery, because if we utilize those antibiotics, the surgeons may not have many antibiotics left to like actually be able to treat these cases. I think that when we're culturing these cases, both as surgeons and as general practitioners and dermatologists, really we need to be culturing the flora from the middle ear post lavage. We know that that decreases the number of isolates that we see, and allows us to more effectively treat the microbes that matter. Even in this study, even though I was, taking little bits of the canal with the bulla epithelium, I feel like what I should have been doing is only taking the bulla epithelium and evaluating that, and that would allow me to target the specific microbes I need to target more appropriately. I think a lot of the time we see so many microbes and we're probably not getting the full story on what's causing the problem. I think one of the other things that I'm probably going to start doing is looking at cytologies from the bulla epithelium, just because I do think we're getting a lot of these enterococcuses, and we're culturing things where we don't necessarily know that every microbe is a microbe that's causing a problem. And if we were able to kind of isolate what we're seeing in terms of bacteria in the bulla, then I think we have a little bit better chance at like treating these appropriately. In general, when these infections start to become untreatable, I think prompt referral is your best option for avoiding someone like me needing to do a TECA and put beads in. Um, does that answer?
Yeah, I think that's great. I mean, basically, I'm just hearing from some of the participants that it was an excellent presentation. And I think I think that that concludes the presentation. So I just want to say, please don't hesitate to email or call me anytime if you have any questions. Please visit carrier.com for more information or to place an order. And we thank you for your time. Thank you, Dr. Kinsey.
So much, guys. Take care.